Welcome everyone to our new publication series in European Radiology, which is called Innovation in Focus. My name is Constantine Nicolaou. I'm with Frodier Garga today.
Hello, Constantine. Lovely to see.
Great to have you. So one of the papers that we are putting into this series first in the bunch is on something that feels like it's already getting there. It's already in clinical routine, which is deep learning methods to accelerate MR imaging. How do you explain how that works? Can you just give us a brief technical overview and maybe how does it change our clinical routine? And how do you feel it's changing biology already?
Thank you very much, Constantine, for introducing this very important topic. And Martin Graves, one of my colleagues, has written a terrific paper expanding this really complex area, if I put it in very simple terms. So I do invite the readers to go and look at this and read it. This is an area where it's rapidly expanding, and as you said, it's already into clinical routine in many aspects. Using deep learning, for example, convoluting neural networks, CNNs, is an important area in order to look at undersampled data, and where we can therefore, through the sparse data, reconstruct it and be able to improve our resolution, decrease reconstruction times. And so the potential for clinical impact is huge. Aspects we're already introducing in clinical practice. There's many great potentials for this in the future.
That would also be my take, and that's the same spirits we're having at our institution. Then do you also see some risks in two ways? First, if you really strongly undersample it, do something with deep learning, is there any risk of losing information from the real image, from the real text space? And if we ask our techs and colleagues to do like 20 MRs an hour and not 3, is this possible? Should we do this? How can we implement this into the workflows? What is your feedback on those two questions?
So there's certainly risks in undersampling, and the key to it is the data sets that we train our deep learning algorithm on, and how we validate that intimately. So those are important aspects. There can be something called domain shift, whereas if we train the healthy volunteer population prior to patients, there may be challenges there. So the validation is absolutely essential to make sure that what we see is truly what is actually represented in the patient. And in terms of the workflow, well, we already do this. And I would put an argument to you that, in fact, this is a benefit, not a disadvantage. It allows us as radiologists to see reduced noise, reduced artifacts, potentially increased resolution, or that might have a secondary effect. And ultimately, that's going to improve the quality of the reports that we produce.
I agree. And I also think we can improve our service because we have more slots. We're faster with MR. Maybe we reduce bottlenecks in terms of waiting time. So it's a fascinating field. Thanks so much for commenting this expert paper. Thanks for listening and for watching, and read the papers.
Indeed.